Welcome to Cracking the Shell on Psychological Science, where we aim to bring you the science of psychology in bite-sized nuggets. In today's episode, we speak with Dr. Jessica Magidson, a professor of psychology here at the University of Maryland. Dr. Magidson is an expert on substance use disorder. Her work spans the globe, from here locally in the state of Maryland, the rural community, and inner city Baltimore, but also globally into South Africa. In today's episode, we talk with Dr. Magidson about her work in rural Maryland, specifically what she's doing to increase access to mental health and substance use disorder resources. Please join us for this episode. Welcome back to another episode of Cracking the Shell on Psychological Science. I'm Mike Doherty, and today I'm here with Dr. Jessica Magidson, the professor of psychology and director of the Center for Substance Use, Addiction, and Health Research, or CSER. Welcome to the show, Jess.
Thank you so much for having me.
So before we get started, do you prefer Dr. Magidson, Jessica, Jess, or something else?
Jess is great, thanks.
Perfect. I want to start with a general question, which is, what exactly is CSER?
So CSER is an interdisciplinary research center on campus here at Maryland. It's the Center for Substance Use, Addiction, and Health Research. And it has been around for a long time. It was first launched in 1990, actually in the wake of the overdose death of the University of Maryland basketball legend, Len Bias. And so for the past 30 years, CSER has been doing amazing research looking at how to increase access to substance use disorder treatment, research, and knowledge throughout our state and throughout the world. We do practical, action-oriented research, really aiming to help individuals, families, and communities with the problems that substance use disorder causes for them.
Yeah, that's amazing. Actually, one of the things that I really like about the CSER mission is that it's really focused on the community and and trying to really address important problems that people in the Maryland community experience. Before we get started on the rest of the interview, though, you also do something else, and it's actually quite interesting. So we're going to just ask you to say a little bit about your lab. So you direct the Global Mental Health and Addictions Program, or GMAP. Can you tell us a little bit about the work that takes place in GMAP?
So GMAP is a research lab that I started in 2018 when I joined the faculty here. And our focus is really in the field of global mental health. So understanding how do we bring interventions and treatments to lower resource contexts, both in the U.S. as well as internationally, focused on how do we integrate mental health and substance use interventions into these unique contexts like HIV care, substance use treatment facilities. We do a lot of work internationally, in South Africa specifically, and looking at how we can take some of those lessons that we learn abroad and translate them back into our domestic work as well.
Oh, that's really cool. I didn't actually realize you brought that work back to the States. That is amazing. Obviously, we could talk about that probably ad nauseum, and there are many things that I know we could talk about today, but I do want to focus on your work here in rural Maryland, which I think is run through CSER. Is that right?
Yeah, so part of it is run through CSER and part is through GMAP. Yep, so it's a collaborative effort. Okay,
well, can you tell us a little bit about the work that you've been doing with CSER and GMAP in rural Maryland?
Yeah, absolutely. So we have two large NIH-funded projects in rural Maryland. The first is we call PRISM, the Peer Recovery Intervention to Reduce Substance Use in rural Maryland. I always forget how the acronyms perfectly work, but it was perfect at the start. But our work there is really looking at how do we increase access to substance use disorder treatment in rural context in Maryland. And so we partner closely with University of Maryland, Baltimore in collaboration with local departments of health. So we work closely with the Caroline County Department of Health. And they have a really cool model where they've taken mobile treatment units or vans and equipped them with telemedicine resources so that folks who are reached by these vans in rural Maryland can access physicians who can prescribe medication and treatment for opioid use disorder in contexts where there's very limited access to services. And so what we've done is we've embedded a research infrastructure into this platform, and we're looking at how specifically peers or people with lived experience can support treatment outcomes for people. So how can we train peers in evidence-based interventions to help support engagement in care, to help support resources to enable people to achieve their recovery and their own substance use disorder treatment goals.
Is this mostly focused on opioid addiction?
So this is focused on both opioid use disorder and other substance. We call it polysubstance use, so people using substances alongside opioid use disorder as well. But it's in the context of an opioid use disorder treatment program.
I grew up in central Kansas, right? And I'm fully aware of the lack of medical resources that rural communities oftentimes face, or I don't know if that's the right word for it, but you know what I mean.
Exactly.
It's like hospitals shut down, centers like health centers oftentimes pop up, but the resources that were there, say, 15, 20, 30 years ago are no longer there. In what way are you feeling this gap?
Yeah, exactly. So what we're finding is people have very limited access to services. So they have to either travel much farther to reach the services that they can receive, or people are not necessarily receiving evidence-based care. So we know that especially for opioid use disorder, people, the gold standard treatment for opioid use disorder is medication, and a lot of facilities that are providing substance use disorder care don't necessarily prescribe medication. And so people may not be able to access services, they may not be able to access high-quality services. And the other piece of this, too, is that people often face a lot of stigma, or there's a lack of kind of confidentiality and privacy around their accessing services, too, that I think is really unique in a rural context. And so that's another piece of what we're trying to address in our work, is helping destigmatize care as well as bring care closer to where people are located.
Okay, so why the unique focus on rural Maryland, may I ask?
Yeah, so we know that people are not able to access services in the same way as urban areas. And so the majority of people, I think it's like over 80% of people, have to travel over 10 miles to be able to access substance use disorder care. And they face a lot of barriers in being able to receive those services. But it's not just opioid use disorder. I know that's a big piece of our work and being able to bring medications and other evidence-based care for people, but it's also other substances that are really common in rural areas. And so the rural communities in Maryland where we're working are hard hit by, again, what we call polysubstance use, or the use of other substances alongside opioid use disorder, things like methamphetamine, cocaine, other stimulants that we don't have evidence-based treatments for. And so part of what we're doing is trying to train peers in approaches that we know work for these conditions that there are not medications yet available. And so we're able to bring services and evidence-based services closer to people who may not be able to access them.
Yeah, this is just kind of an aside, but I recently read that at least for opioids, there seems to be a downturn maybe in substance use disorder cases. Is that right?
Yeah. So in some communities, so overall we are seeing progress. We're seeing a reduction in overdose-related deaths nationally around opioid use disorder and other substances. But when we look specifically at different communities and different populations, we're not seeing necessarily the decrease across all communities. So I think it's progress. It's showing that especially our harm reduction efforts and access to things like naloxone or other prevention and treatment services are making an impact. We just need to make sure that that impact is kind of equitable across the country. And I think we see particularly rural communities where there is limited access to services, maybe a population particularly vulnerable for ongoing problems around substance use.
Can I ask you a question about the consequences of addiction?
Yes, definitely.
'Cause you're an expert in this whole field, and I know you've studied this for a number of years, and certainly probably have seen firsthand some of the consequences, both personally and socially, that addiction can have. Can you tell us a little bit about what you see, or what the research says about the consequences of addiction and the broader cost to society?
Definitely. So when we think about what makes something a substance use disorder versus active use, it's really about ongoing use despite problems or consequences that people are facing in their lives. And so people continuing to use despite, a lot of the harms or problems that it people can face, both individually as well as how it affects families and communities around people who are using. And so it becomes, for some people, a really like all-consuming cycle where it takes over kind of all moments of people's lives, given the physiological effects of substance use and given the profound effects it can have on our day-to-day lives. And so one thing that we do in our work is we bring people in with lived experience. And so I was mentioning we have 2 projects right now in rural Maryland, and the second project it's called Artemis, and it's about creating an infrastructure for community members and patients, people with lived experience, to have a voice in the research process so that they can share with us throughout all phases. These are the harms that substance use causes in my life. This is what is important to us, and we're not creating research priorities without having these voices of people in lived experience. So that's our second project, Artemis. And I think that one of the advantages of having a project like Artemis, where it's about creating a space for people with lived experience, is that we're never forgetting these profound impacts that substance use can have on people's lives. And so we hear it on a regular basis. I think we hear effects on things like employment, on relationships with family members. It can take over everything. And so there are profound effects both at the individual level as well as for communities and families surrounding people. That being said, we do know that with treatment and with evidence-based support and care and recovery resources, people can recover. And I think there's a lot of stigma in society or misconceptions about what a substance use disorder pathway can look like. And we've seen through these projects that I'm sharing, we've seen that once people are given the tools and resources that they need and the support they can really make a full recovery and be engaged in their lives and in their communities in really powerful ways with the right supports.
Yeah. Is it safe to say that addiction can affect anybody?
Yeah, absolutely. It can. It can affect all communities, and no one is immune from something like a substance use disorder.
Yeah, this is really an amazing set of projects that you have going on, and I really am in awe that you're able to carry these things out. It's so important, the work you do, but it's not free, right? So I'm curious, how do you manage to cover the cost on this type of work?
Yeah, no, thank you. So these projects that I highlighted today are funded by the National Institute of Health. They're funded by the National Institute of Drug Abuse, or NIDA. We receive large federal grants for this work, and part of what these grants do is not only fund the staff and the teams and the resources to carry out the trials or to create this infrastructure for Artemis of community members having a voice in the research process, but it also brings people together. So each of these trials have networks of researchers that come together on an annual basis to share progress, to share priorities, and it advances the science not only in the individual projects, but having these cohorts of people working together to figure out how can we best support people in this country who are suffering from a substance use disorder.
Yeah, so your network extends across the U.S. Does it go beyond the U.S.?
Personally, I do a lot of work internationally as well. These specific grants are really focused on how do we better increase access to substance use services in rural communities in the U.S., but certainly a lot of our team's work is figuring out how can we learn from lessons all over the world to better innovate around access to substance use treatment here.
So if someone is interested in your work and wants to learn more, or is curious about having you come to their community, how can they get in touch, or do you have information you can share?
Would love that. Please check out our CSAR website. So it's CSAR.umd.edu.
Can you spell that out?
Yeah, CESAR.umd.edu. One of the things that CSAR has been an expert at for a long time prior to me starting as director is around dissemination. And so we really try to highlight findings on our website, trends, other resources. We've also developed other websites for these specific projects to make them more accessible for people in the community. So we have a new website about to launch, or I think just launched, for our Artemis project. So that's artemis-maryland.com. We also have a few other linked podcasts and websites within the CSAR website to give more information about our trials.
Jess, It has been a pleasure talking to you about this incredibly important work, and thank you for coming on and sharing.
Thanks so much for having me.
I hope we can bring you back again and talk about more of your other projects.
I would love that. Thank you.
All right. Thank you. Bye-bye.